Prosthetic valve dysfunction and complications. They include structural valve failure. Number 2, paravalvular leak. Number 3, thrombosis and thromboembolism. Number 4, prosthetic valve endocarditis. Number 5, post-operative management. Prosthetic valve endocarditis. Prosthetic valve dysfunction and complications. Number 1, structural valve failure. Structural valve failure. Bioprosthetic valves are vulnerable to degenerative changes. Structural failure rates for biological valves, although rare in those over 70 years of age, can reach 60% after 15 years. However, newer biological valves have a reoperative rate of less than 10% at 20 years. Structural failure of a mechanical valve is generally uncommon. Structural valve failure. Then paravalvular leak. Number 2, paravalvular leak. Early onset paravalvular leak usually results from technical difficulties at insertion. Early onset paravalvular leak usually results from technical difficulties at insertion. It causes due to technical difficulties. Late onset leaks. Early onset leak, then late onset leak. Late onset leaks can occur and may be related to an episode of endocarditis or in the presence of bioprosthesis, leaflet degeneration. Late onset leaks can occur and may be related to an episode of endocarditis or in the presence of bioprosthesis or leaflet degeneration. The leak can cause hemolytic anemia. Or hemodynamic compromise, and the valve may need replacement. Thrombosis and thromboembolism. Number 3, thrombosis and thromboembolism. Thrombus formation on a prosthetic valve remains the most common complication of mechanical and biological valve. It is the most common complications. The risk of thromboembolism is greater with a valve in mitral position, mechanical or biological, than with one in the aortic position. Improved hemodynamic function lowers the probability of thromboembolism. The incidence of thromboembolism in current mechanical valves is 0.5 to 3% at patient years. Thrombus formation. Thrombus marked T and illustrated with arrows on the moving component of a ball and case valve. Thrombus marked T and illustrated with arrows on the moving components of ball and case valve. Thrombus formation on a prosthetic valve remains the most common complications of mechanical and biological valves. The risk of thromboembolism is greater with a valve in mitral position, mechanical or biological, than with one in the aortic position. Mitral position, and this is aortic position. So the risk of thromboembolism is greater with the valve in the mitral position. More risky, mechanical or biological, than with one in the aortic position. Improved hemodynamic function lowers the probability of thromboembolism. The incidence of thromboembolism in current mechanical valves is 0.5 to 3% per patient year. Prosthetic valve endocarditis. The incidence of prosthetic valve endocarditis or PVE. The incidence of prosthetic valve endocarditis or PVE is 2 to 4%. The risk is lifelong and is at its greatest in the 3 months after surgery. The incidence of PVE or prosthetic valve endocarditis is higher with mechanical and bioprosthetic valves and lowest with homograft and autograft. Higher in case of mechanical or bioprosthetic valves and lower with the homograft and autograft. The diagnosis is suspected following symptoms of septicemia, appearance of a new murmur or a septic embolus. It is confirmed with echocardiography. Which may show vegetations and even abscess formation. A high index of suspicions is required and early multiple blood cultures are needed to confirm the diagnosis. Identify the infective organism and choose appropriate antibiotic therapy. The most common organism that can lead to PVE PVE prosthetic valve endocarditis. The most common organism that can lead to PVE or prosthetic valve endocarditis are Staphylococcus species, particularly Staphylococcus epidermidis in early prosthetic valve endocarditis, and Staphylococcus aureus in late. Staphylococcus epidermidis early and Staphylococcus aureus at least 50% of cases. The Streptococcus species, usually Streptococcus viridans, but also Streptococcus pneumoniae and less commonly gram-negative bacilli, as well as fungal organisms. The treatment of choice is early aggressive is early aggressive intravenous antibiotic therapy. Early aggressive intravenous antibiotic therapy. Antibiotic therapy. The most common organisms that can lead to prosthetic valve endocarditis or PVE. Serial echocardiography to assess the extent of the infection into the surrounding myocardial tissue, as well as functional assessment of the infected valve, may help in optimizing decisions on timing of surgical intervention. The prognosis of PVE, prosthetic valve endocarditis, remains poor, with an overall mortality rate over 20%. Now, postoperative management. Postoperative management, antibiotic prophylaxis and antithrombotic therapy. Antibiotic prophylaxis and antithrombotic therapy. Antibiotic prophylaxis. Currently, the National Institute for Health and Care Excellence, National Institute of Health and Care Excellence, recommends that prophylactic antibiotics are not required for the patients with prosthetic valve and dental procedures. Other leading European bodies have recently supported the above recommendation, as there is no strong evidence to the contrary. Antithrombotic therapy. All patients with mechanical valves require warfarin, usually started on the first or second postoperative day. The use of anticoagulation or antiplatelet therapy with biological valves is variable and depends on the patient's underlying rhythm postoperatively and surgeon's preference. Mitral valve disease. Bicuspid valve or mitral valve. Mitral valve disease, mitral regurgitation and mitral stenosis. Mitral regurgitation and mitral stenosis. Mitral regurgitation and mitral stenosis. Mitral regurgitation, mitral regurgitation described under pathophysiology, clinical features, investigations, indication for surgery. Mitral stenosis described under pathophysiology, clinical features, investigations, indications for surgery. And finally, mitral valve operations. Mitral valve repair, mitral valve replacement, and mitral valve PCMV repair. Mitral valve repair. Mitral valve disease. Mitral regurgitation. First of all, mitral regurgitation. MR. Any pathological process affecting the mitral valve apparatus may lead to mitral regurgitation. As such, there are many causes of regurgitation and they can be broadly classified into four headings. Number one, pathophysiology. 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 First of all, there is an important distinction between the acute and chronic mitral regurgitation. Between the acute and chronic mitral regurgitation, the former is usually the result of ischemic papillary muscle rupture or following the infective endocarditis, whereas the latter is the result of myxomatous degeneration or fibroelastic changes in the leaflets. The former, or acute mitral regurgitation, is the result of ischemic papillary muscle rupture. Ischemic papillary muscle rupture or following infective endocarditis whereas the latter is the result of, or chronic mitral regurgitation is the result of myxomatous degeneration or fibroelastic changes in the leaflets In acute mitral regurgitation, the left ventricle ejects blood back into a small. The left ventricle This is left ventricle. In acute mitral regurgitation, the left ventricle ejects blood back into a small, poorly compliant left atrium. This is left atrium during ventricular systole. This leads to an abrupt rise in the left atrial pressure. Abrupt rise in left atrial pressure. Followed by rise in pulmonary venous pressure. Increase pulmonary venous pressure. And finally causes pulmonary edema. In chronic mitral regurgitation, the process is sufficiently slow to allow compensatory left ventricular dilatation, and hypertrophy. The dilatation of the left atrium without any significant increase in pressure, so protecting the pulmonary circulation. As the disease advances and left atrial dilatation can no longer accommodate, left atrial pressure begins to rise. Leading to a rise in pulmonary venous pressure, and progressively pulmonary congestion with eventual congestive cardiac failure Now, causes of mitral regurgitation and likely pathology. Causes of mitral regurgitation and likely pathology: degenerative, ischemic, rheumatic, and infective. Degenerative causes: myxomatous degeneration of the valve and the subvalvular apparatus by Barlow's disease. Fibroelastic deficiency in elderly patients, senile calcification or calcified annulus, connective tissue disorder, Marfan syndrome, Ehlers-Danlos syndrome, disruption of the mitral valve apparatus. Ischemic: capillary muscle rupture following myocardial infarction, dynamic mitral regurgitation as a result of transient ischemia, poor left ventricular function, most common functional cause secondary to myocardial ischemia. Rheumatic: previous acute rheumatic fever, stiffened leaflets unable to cope. Infective: endocarditis, leaflet destruction and perforation. Clinical features: in acute mitral regurgitation, Clinical features: in acute mitral regurgitation, the patient is usually unwell. Acute mitral regurgitation, patient is usually unwell. Clinical features: acute, chronic. In acute mitral regurgitation, the patient is usually unwell, presenting with clinical and radiological events of acute pulmonary edema and a loud apical pancytosolic murmur. Patients with mild chronic mitral regurgitation are usually asymptomatic with progressive pulmonary congestion. With progressive pulmonary congestion. ছোট ছোট লেখা কেন রিগার্জিটেশনের সময় তো তোমার ভালভ পুরোপুরি ক্লোজ হয়, তো ওই জায়গায় যখন তোমার ভেন্ট্রিকুলার সিস্টল হয় তখন মাইট্রাল ভালভ দিয়ে কিছু ব্লাড আবার অ্যাক্টিভে ব্যাক ফ্লো হয়, দেন ওটা তো হচ্ছে পালমোনারি ভেনে ইয়া যাবে, প্রেসার বাড়াবে, আলটিমেটলি এটা লাংসে যাবে। যতক্ষণ তোমার ভেন্ট্রিকুলার সিস্টল চলবে ততক্ষণই হচ্ছে ব্লাড ব্যাক ফ্লো হয়, তো তখন একটা অ্যাবনর্মাল সাউন্ড শোনা যায়, এই ট্রান্সিস্টলিক মানে সম্পূর্ণ সিস্টলের সময় যে তোমার কি হয়। হ্যাঁ, এখানে সুন্দর করে জুড়ে যে তোমার সাউন্ড হবে ওটাই এখানে সুন্দর করে এক্সপ্লেইন করা আছে। With progressive pulmonary congestion and left ventricular failure, the patient develops fatigue, dyspnea with progressive pulmonary congestion and left ventricular failure. The patient develops fatigue, dyspnea on exertion and orthopnea. and orthopnea. The development of atrial fibrillation with left atrial dilatation is common. The development of atrial fibrillation with left atrial dilatation is common. The enlarged left ventricles The enlarged left ventricle leads to a heaving apical impulse. And a pansatosolic murmur. Investigation. Investigations of mitral regurgitation. ECG. Number 1 investigation. ECG. ECG may show left atrial hypertrophy. ECG may show left atrial hypertrophy. ECG may show left atrial hypertrophy. Bifid P waves. Bifid P waves. Left ventricular hypertrophy. And atrial fibrillation. Cyst radiograph. Number 1 ECG. Number 2 cyst radiograph. There may be cardiomegaly with prominent pulmonary vasculature. Cardiomegaly with pulmonary vasculature. Echocardiography. This is often combined with color flow Doppler imaging. Which shows the severity of the regurgitant jet of mitral regurgitation. Coronary angiography. Number 4 coronary angiography in patients greater than 40 years of age to investigate the coronary artery. Number 5 cardiac MRI. Increasingly popular as it can give detailed information on structure and function. Indications for surgery. In case of mitral regurgitation. Indications for surgery. For patients with primary mitral regurgitation include severe mitral regurgitation in symptomatic patients or severe regurgitation associated with changes in left ventricular function or dimension, such as left ventricular end systolic diameter. Left ventricular end systolic diameter. systolic diameter. As evidence suggests that any changes in ventricular function in the setting of primary mitral regurgitation is usually associated with significant mortality if not corrected. If not corrected. Features and pathophysiology of mitral regurgitation. There is a loud parasystolic murmur, and the left atrium enlarges. The left atrium enlarges. The left ventricle enlarges as a consequence of volume overload. It is also recommended to address severe mitral disease in the same setting if a patient is undergoing cardiac surgery for a different region. The treatment of mitral regurgitation. Secondary to ischemic heart disease remains controversial, and current evidence suggests that patients with severe ischemic regurgitation may benefit from mitral heart replacement, while patients with moderate regurgitation should usually undergo repair along with coronary artery bypass grafting if indicated. Finally, the treatment of mitral regurgitation secondary to ischemic heart disease remains controversial, and current evidence suggests that patients with severe ischemic regurgitation may benefit from the mitral valve replacement, while patients with moderate regurgitation should usually undergo repair with coronary artery bypass grafting. Next, mitral stenosis. Mitral stenosis. The most common mitral stenosis. The most common cause of mitral stenosis remain rheumatic fever, despite the fact that incidence of the incidence of overt rheumatic fever in resource-rich countries has decreased. During the healing phase of the acute rheumatic fever, the valve leaflets become adherent to each other at their free border, so that the commissures become obliterated and the valve orifice narrows. Symptoms of mitral stenosis usually develop more than 10 years after the acute attack. Pathophysiology. Mitral stenosis show ventricular filling during diastole. Pathophysiology shows ventricular filling during diastole, and the pressure in the left atrium rises to maintain the cardiac output. This leads to atrial hypertrophy. This leads to atrial hypertrophy and dilatation. And atrial hypertrophy and dilatation. Pulmonary congestion results from the rise in the left atrial pressure. Pulmonary congestion. Pulmonary congestion. Pulmonary congestion results from the rise in the left atrial pressure, but with time, the lungs are protected against pulmonary edema by constriction of the pulmonary vessels. However, this adaptive response, along with the passive back pressure generated by the rise in the left atrial pressure, leads to pulmonary hypertension. This leads to an increased demand on the right ventricle. This leads to an increased demand on the right ventricle. With eventual right heart failure and tricuspid regurgitation. The development of atrial fibrillation is common and can lead to a significant reduction in cardiac output. Atrial fibrillation predisposes to thrombi forming in the left atrium. Formation of thrombi in the left atrium, which may embolize to the systemic circulation. Clinical features. Causes of mitral valve disease. Causes of stenosis, rheumatic heart disease common, calcification of the valve or chordae, congenital rare, regurgitation, rheumatic heart disease, valve prolapse, left ventricular dilatation or hypertrophy, ischemia, bacterial endocarditis. Now clinical features. Patients may remain asymptomatic for years and then presents with symptoms. Clinical features. Patients may remain asymptomatic for years and then presents with symptoms when the heart is stressed by an event such as pregnancy, fever, chest infection, or with the onset of atrial fibrillation. The common symptoms are fatigue and dyspnea. On exertion, which results from the combination of reduced forward flow and increased back pressure. The resulting pulmonary congestion adds to breathlessness. And may produce a cough or hemoptysis. If mitral stenosis is advanced, mitral stenosis advances, if mitral stenosis advanced, there may also be a right ventricular hip. There okay, right ventricular hip due to right ventricular hypertrophy in response to pulmonary hypertension. Auscultation reveals an opening snap soon after the second heart sound. Auscultation reveals an opening snap. Auscultation may reveals an opening snap soon after the second heart sound. First heart sound, second heart sound. Auscultation may reveals an opening snap. There is a opening snap soon after the second heart sound, as the diseased valve is opened forcibly by the high pressure in the left atrium. The reverse happens when the valve closes and there is a loud tapping first heart sound. Loud tapping first heart sound. In addition, a rumbling mid-diastolic murmur can be heard. The duration of murmur is related to the severity of the mitral stenosis, increasing in length as the stenosis becomes more severe. Investigations of mitral stenosis. Number 1. Investigations includes number 1, ECG. ECG may show left atrial enlargement. Left atrial enlargement, P mitrally or atrial fibrillation. Right axis deviation and other ECG signs of right ventricular hypertrophy. Tall QRS complexes in right ventricular leads V1 to 3 may also be present. Tall QRS complex. Complexes in the right ventricle leads V1 to 3 may also be present. Chest radiograph. Number 2, chest radiograph. There is a small aortic outline and a prominent pulmonary artery. The left atrium is enlarged, sometimes to an enormous degree, along with upper lobe. The right ventricle also appears enlarged. Chest radiograph of long-standing mitral stenosis showing a massive left atrium. Then echocardiography. In combination with color flow, Doppler imaging. Number 3, echocardiography. in combination with color flow Doppler imaging allows assessment of the flow across the valve and therefore the degree of stenosis. Transesophageal echocardiography or TOE, transesophageal echocardiography, may be better at assessing valvular morphology in detail and excluding the presence of an atrial thrombus. Coronary angiography. Coronary angiography. To investigate the coronary arteries, cardiac MRI, then right heart catheterization. Number 6, cardiac MRI. Number 7, right heart catheterization. Right heart catheterization. Finally, indications for surgery. Indications for surgery. Indications for surgery. Indications for surgery include medical management includes of anticoagulation in patients with use of anticoagulation in patients with atrial fibrillation or left atrial enlargement. Left atrial enlargement. Left atrial enlargement. Left atrial enlargement. Anticoagulation is used. Tachyarrhythmias including fast atrial fibrillation that may lead to decompensation and cardiac failure should be treated. Rate controlling agents that are mainstay of treatment, diuretics, anticoagulants, anticoagulation in patients with atrial fibrillation or left atrial enlargement. Tachyarrhythmias including fast atrial fibrillation that may lead to decompensation and cardiac failure should be treated. Rate controlling agents that are mainstay of treatment. Rate controlling agents. Rate controlling agents. Rate controlling agents are the mainstay of treatment. Diuretics may provide some benefit. The principal invasive intervention is percutaneous mitral balloon valvuloplasty. Percutaneous mitral balloon valvuloplasty PMBV. Surgery is indicated for severely symptomatic patients who have failed or who are unsuitable for percutaneous mitral balloon valvuloplasty. The prognosis is determined by the severity of the stenosis, the size of the atrium, the onset of atrial fibrillation, rising pulmonary artery pressure, and the unpredictable risk of embolism from a large fibrillating atrium. Surgical options include mitral valve repair or mitral valve replacement. Formerly common surgical procedures such as closed or open commissurotomy are now being performed. Features of Physiology of mitral stenosis. The aorta and left ventricle. The aorta and left ventricle are relatively small because of chronically reduced cardiac output. The atrium is enlarged. The atrium is enlarged and may fibrillate, become stagnant, and contain a thrombus. The ventricle fills with a turbulent jet that may be detected as a diastolic murmur or a thrill at the apex. The prognosis is determined by the severity of the stenosis, the size of the atrium, severity of the stenosis, severity of the stenosis, then size of the atrium, severe of the stenosis, site of the atrium, the size of the atrium, the onset of atrial fibrillation, rising pulmonary artery pressure, and the unpredictable risk of embolism, from a large fibrillating atrium. Surgical options include mitral valve repair. Mitral valve repair or mitral valve replacement. Formerly common surgical procedures such as closed or open commissurotomy are now rarely performed. Closed or open commissurotomy. Closed or open commissurotomy are now rarely performed. Mitral valve operations. Mitral valve operations, depending on the type of procedure and approach. Mitral valve operations. Depending on the type of procedure and approach to the mitral valve, a median sternotomy or occasionally a right thoracotomy is performed. Approach to the mitral valve: a median sternotomy, or occasionally a right thoracotomy is performed. Sternotomy or right thoracotomy is performed. The mitral valve can be approached directly through the right atrium in the interatrial group. Through the right atrium, the mitral valve can be approached directly through the left atrium. In the interatrial group through the right atrium, and then the interatrial septum or through the left atrial appendages, or through the left atrial appendages. Mitral valve repair. Mitral valve repair. Mitral valve operations include mitral valve repair, mitral valve replacement, and percutaneous mitral valve repair. Percutaneous mitral valve repair. Number 1, mitral valve repair. Mitral valve repair. The restoration of normal valve function and preservation of mitral apparatus is preferably to replacement in specific groups or pathology, as it can be associated with improved long-term ventricular remodeling and function. This approach reduces the bleeding complications associated with anticoagulants. The functional classification system developed by Carpentier serves as a guideline in the valve reconstruction. It allows classification of any mitral insufficiency into one of three groups according to the amplitude of the leaflet motion and provides a useful framework for the mechanisms of failure of the mitral valve. As a rule, several valvular lesions or abnormalities are involved in a functional abnormality with specific technique developed to correct its lesion. At surgery, the anatomy of the valvular apparatus. At surgery, the anatomy of the valvular apparatus and subvalvular structures have to be carefully inspected. In particular, the extent of the annular dilatation, leaflet prolapse, and cordial dysfunction are assessed. The mitral valve reconstruction is completed using various techniques, including insertion of a prosthetic ring annuloplasty. Prosthetic ring annuloplasty. Operative view of the completed repair of a mitral valve using a Carpenter-Edward annuloplasty. Ring. Triangular or quadrangular resection of the leaflet. Use of a sliding plasty. Quadrangular or triangular or quadrangular resection of the leaflet. Use of a sliding plasty. Caudal shortening. This is the caudal shortening, caudal transposition, and the neocordia implantation. There are many different techniques, which indicates that no one technique addresses all the issues that can occur with mitral regurgitation. Valve repair. Valve repair, however, offers a better preservation of ventricular function and avoids the need for prolonged anticoagulation, as well as valve-related complications such as PVE, ventricular endocarditis, or structural dysfunction. Recent advances in surgical techniques and the development of different types of rings has led to increased use of mitral valve repair with excellent results, making it the standard operation. The operative modality is 1 to 3%. One of the major issues related to the mitral repair is the incidence of regurgitation repair. Regurgitation recurrence, which varies between series but can be up to 30% at 5 years. At 5 years. It seems that this is related to which leaflet is repaired and the amount of foreign materials used in the repair. A mitral valve replacement. Mitral valve mitral valve replacement. Number 2, replacement. When valve repair is not feasible, mitral valve replacement is necessary. Valve repair is not feasible, mitral valve replacement. Mitral valve replacement is necessary. Usually this involves a median sternotomy and access to the left atrium on CPB, cardiopulmonary bypass. Involves a median sternotomy and access to the left atrium The diseased valve is excised and suitably sized mechanical or bioprosthetic valve is implanted. The atriotomy is closed. The atriotomy is closed following the dearring of the left heart. Inoperative TOE can be used to assess the adequate valve function. The operative mortality rate for elective mitral valve replacement is approximately 5 to 6%. This depends largely on the state of the myocardium and the general condition, including age of the patient. Common serious in-hospital complications include stroke and renal failure. Complications include stroke and renal failure. Although any complication of heart surgery is possible, the longer-term prognosis for patients following the mitral valve replacement is generally good in comparison with the natural history of the mitral valve disease. Indeed, more recent evidence suggests the patient with ischemic severe mitral regurgitation can benefit more from the valve replacement when compared to repair. Now, percutaneous mitral valve repair. Percutaneous mitral valve repair. Mitra clip. Percutaneous mitral valve repair or Mitra clip is a device used to reduce mitral valve regurgitation. The method involves suturing of the leaflet of the mitral valve. Suturing of the leaflet of the mitral valve so that regurgitation into the left atrium is prevented. The valve continues to open through the sides of the suture and therefore the blood continues to flow into the left ventricle. Although this method is less invasive, associated with rapid recovery and reduced in hospital stay. It is, however, technically demanding, and long-term durability of the results of the device is unknown. Recent data suggests that mitral clip or percutaneous mitral valve repair may be suitable for a small subset of high-risk patients or patients with chronic heart failure. It can subset of high-risk patient or patients with chronic heart failure, but not for the vast majority who are better severed by surgery that leaves them with substantially less mitral regurgitation. Substantially late mitral regurgitation.